Hello, my name is Dr. Fred Sylvester from New Hanover Chiropractic, and welcome to this episode of Health Talk. Today we have a very distinguished guest, Dr. Glenn Lipton. He is owner-operator of Premier Orthopedist. Graduated from Temple in 2001, Drexel in, I think, 2005, somewhere in that area?
2006, yes, sir.
Yeah. And he's been servicing our area orthopedically since 2006. He's brought a great deal of respect and integrity back to the orthopedic world. It's been a pleasure to work with you over the last few years here, and I look forward to having this interview with you.
Thank you.
Today we're going to talk about shoulder rotator cuffs, and we're going to look at how that implies and how that affects people and how that goes into their lifestyle at this point. So, Dr. Lipton, thank you for being here.
Thank you for having me.
Absolutely. So, let's go ahead and start talking about the normal anatomy of a shoulder.
Sure.
What is it?
The normal anatomy of the shoulder and the rotator cuff. The shoulder is made of several bones. The humerus bone, which is the arm bone, and then you have the clavicle, and then you have the glenoid, where the humeral head articulates with. Mm-hmm. You have several muscles in there. There's a compilation of 4 of them, and that's the rotator cuff. You have the top muscle, which is supraspinatus. You have the back muscle, which is infraspinatus. The front muscle, which is the subscapularis, and the teres underneath. Mm-hmm. It's a very, very common injury to your shoulder for these complex of muscles. Approximately 2 million people have complained of shoulder pain and saw a physician in 2013.
So when you're looking at that from that component of it, you have a very shallow joint with a lot of muscles that are giving support and stability to it at this point. Does that make we'll say, the shoulder more vulnerable than the hip?
I don't know if it makes it more vulnerable, but we're using our arms, our upper extremities, to do many activities, mm-hmm. and the shoulder is such a complex joint that complex of muscles can be injured relatively easily.
Okay, so when we're looking at it, what would you say the prevalence is of like rotator cuff tears, and what actually is a rotator cuff tear? We'll even start there. That'll probably be better.
So rotator cuff tear is where one of the muscle tendon units of the 4 muscles that I mentioned tears. The most common one is the supraspinatus tendon, mm-hmm. and I can show you a picture of that. So this is the normal anatomy here, and we'll go over to where the tear is. This mm-hmm. is, again, the normal anatomy. This is the top muscle, the supraspinatus, and then you have the one in the front called the subscapularis. You can't see the one in the back right here. So here is a side view, which is very good. Here's the normal anatomy with all of 3 of the muscles shown, and here's a tear of the supraspinatus, and that's the most common muscle to be torn. And so the rotator cuff, it elevates your arm, it provides stability, and it enables also does rotation. So when this muscle is torn, you have pain in your arm, and you have decreased function if it's a large full thickness tear.
Okay. And is there a difference between we'll say the tears themselves? What type of tears can you have in that?
Yes, there's a whole multitude of problems with your rotator cuff. It can be as simple as just an inflammation to the rotator cuff, which is a tendinitis of mm-hmm. sorts. That's treated in a conservative fashion, usually very successfully. And I'll go through all the treatments in a moment. Mm-hmm. Then you can have a partial tear, which is not the full thickness of the tear. The partial tears are also usually amenable to conservative treatments. When you have a full thickness tear and you lose function, those are the ones, if they fail the conservative treatments, that go to the surgical treatment protocols.
Okay. And when you're looking at tears, I mean, are there risk factors that would predispose somebody to a tear?
Certainly. So if you have a job where there's a lot of overhead use, you play sports with a lot of overhead use of your arm, what happens is there's some degeneration that can occur over time because you're stressing the rotator cuff significantly. So what ends up happening is those are more of a degenerative pattern of tearing. The other thing that can happen is if you would find yourself in a traumatic event in the younger population, those can tear from a traumatic injury. So you fell on an outstretched arm. If you had a dislocated shoulder where it stresses the shoulder joint, the rotator cuff can get torn very easily. Okay. The other thing that happens is as we age, our blood supply decreases a little bit, and also the degeneration. So as you get older, there's an increased prevalence of rotator cuff tears in the population. And those can be without any injury at all. People may report, hey, I fell or I tripped or I lifted an object in a jerking fashion, and those folks can sustain a rotator cuff tear.
Sure. So when you're looking at it from that perspective of, trying to differentially diagnose, if a patient walks into your office with shoulder pain, how are you working them up?
So the first thing that I do, because the shoulder is innervated by the nerves coming out of your neck. The first thing that I do is I check someone's neck. Every single patient that comes into my office gets a complete cervical spine exam as well as a shoulder exam, because we want to delineate whether or not there's a different cause of the pain other than the actual shoulder.
Sure.
So we go ahead and we do the neck exam. Saying the neck exam is normal, then we proceed to the shoulder exam. I check the patient's range of motion and strength because we're concerned about other things as well. Shoulder pain isn't only caused by rotator cuff pathology. You could have significant arthritis in your shoulder joint, in which case sometimes there'll be a lack of motion, there'll be crepitus. You'll find other keys. What we do to delineate the two, the first thing that we do is get an x-ray. The x-ray doesn't show rotator cuff tears, but it does show arthritis.
Okay.
So what we'll do is we'll look carefully at the x-ray and we'll see, is there a component of arthritis there. If it's mild arthritis, it usually doesn't show up too much on an x-ray, but then we would get an MRI to elucidate that information.
Okay.
Other things that can happen is not only in the shoulder is there the rotator cuff, but just above it is your acromioclavicular joint. And that's part of your shoulder complex. And people can have pain on the top part of their shoulder. So a good physical exam, also looking at their medical history, will elucidate a lot of different things. There's another pathology that happens in the shoulder from the standpoint of evaluating shoulder pain is if someone has a significant loss of motion, they can get something called adhesive capsulitis or a frozen shoulder. The frozen shoulder can be caused by many different things. It could be a small injury where people stop moving the arm and then it stiffens up. The other thing is people with thyroid disease, those with diabetes, have an increased incidence of frozen shoulder with a normal rotator cuff and no arthritis. And those are treated purely conservatively, going and getting the therapy, for instance, in this facility, and getting that motion back, doing it all in conservative levels.
Gotcha. So when you're looking at it, say you diagnose your shoulder tear and that type of stuff, a rotator cuff tear, and does a person have a choice whether to treat or not? And if they don't treat, are there consequences that would have ramifications in the future?
Certainly. I explain to all patients that we talk about, we identify their tear, we go through the reason why we're getting an MRI. After we get the MRI, we evaluate what type of tear they have, a partial thickness tear, a small full thickness tear, or a large full thickness tear. The partial thickness tears, I really do try to continue on the conservative pathway. It's very, very, very rare for me to operate on a partial thickness tear. It's happened rarely, but usually I can treat them with anti-inflammatory medications. I'm big in the physical therapy and the rehab. I think that's a critical component to improving your function and getting rid of your pain. Sometimes they'll get an injection in their shoulder. You know, that will go a long way, getting the anti-inflammatory medication, a steroid of sorts, cortisone, I'm sure most people know of, into the shoulder, above the shoulder joint, so it calms everything down so they can do the rehab, get strong again. When I see a partial thickness tear that's almost full thickness and they didn't improve with a shot and they didn't improve with rehab, then I offer them the operative intervention. That and the full thickness tears that fail the conservative measures. So I do go operative in that stage. We can talk about the operations afterward, but so if you at the decision-making process, do I get surgery or don't I get surgery? If you have a large tear, what would be the problem if you didn't get it done? So the big concern would be continued loss of function, continued intermittent pain as you were using your shoulder, and you would be weaker because you wouldn't be able to elevate your arm like you were before. If you decide to go the operative route, there are also complications that way, and everybody's medical history needs to be carefully evaluated to see what the appropriate step is. If you go the operative route, there's the concern and complications. You could get a post-surgical frozen shoulder. You could get an infection. It's exceedingly rare. I've never seen one in my practice. However, they do exist, and I always warn my patients, I haven't had one yet, but there's a chance that you could get one.
Absolutely.
There's the chance of nerve injury. There's the chance that it fails and that your rotator cuff does not heal down. And there are certain cases where the tear is so far retracted back that it's not amenable to a standard repair where we bring the tendon back to its normal position and suture it in place with anchors and suture. In those cases, what we like to do is we talked about the patient about several other procedures, and two relatively new procedures that are out there is we have something called a superior capsule reconstruction. So when you have a younger person, they don't really have any arthritis, but they have this chronic tear that maybe they ignored and it's scarred in and we can't fix it now. We offer that patient the reconstruction. It's where we put a patch on the top of the rotator cuff and we'll reconstruct it with that. And we found in those cases that many of the patients regain both strength, motion, and most importantly, their pain goes away. I've done many of these procedures in the recent past, and universally the patients have no problem with pain. It's a very, very good alternative. The other thing to do, if a patient has arthritis and a bad rotator cuff tear, we offer them something called a reverse shoulder replacement. And the reason we don't do a standard shoulder replacement of them is because that patient not only has the arthritis, but they also have a rotator cuff tear. And in those cases, we have an implant now that actually, instead of we change how the normal biomechanics in the shoulder are. We shift the center of rotation out a little bit. And now, instead of utilizing the rotator cuff to lift your arm and do the motions, we're using the lateral muscle a little further outside, deltoid, to do all the work. Now, we would much prefer to do a primary repair, but if we're able to do it this way and restore function and get rid of pain, this is a great alternative for people that have both a rotator cuff tear and severe arthritis.
So most people that you talk to with shoulders, they say they had arthroscopic surgery. Can you explain that and what that really entails? Because that seems like the major.
So there's 3 different ways to actually do the rotator cuff repair. There's one, the standard, which was originally described, where it's a big giant incision. You go in there, you open it up, and you repair the rotator cuff when you're directly looking at it. The problem with that is there's complications that go with those. You have to make a large incision, you're cutting through muscles, and if those muscles don't heal, you have those complications. There's an increased risk of infection because it's a larger opening. It's more tissue to heal, it's harder to heal, and the patients have a more pain in the beginning. Now, the studies show that long term, a year out, there's no difference as long as there's no complications between an open rotator cuff repair and the poke hole surgery, which is arthroscopic. There are some doctors out there that are doing a mini open, a small incision with an arthroscopic assist. Okay, so it's got a mini open attempt. Many of the specially trained orthopedists today only do arthroscopic. I only do arthroscopic poke hole surgery. We've had very, very good results, and we have so many techniques that are arthroscopically successful and instruments that have been refined through the years that I don't feel it necessary to make an incision anymore. Not that it is wrong if your orthopedist recommends that and they're comfortable with that procedure more than arthroscopic. You should absolutely do what they recommend, because if they're more comfortable, they're going to do a good job and you're going to get better function than doing a procedure they're not used to.
So after you differentially diagnose, you put the treatment out, they accept surgery, they do that type of stuff. What would be the experience that the patient would be experiencing over the next year?
Yeah, so
surgical.
What I like to do is start with the most simple stuff when I talk to my patients. I go through as part of my complications, and I discuss that you could have pain as part of your procedure. So I tell people what we do is we have to give them a block in their shoulder for the day of surgery. So just before surgery, they get a block in their shoulder, they get their surgery, it's successful, and they go home. So for the first few hours at home, you have a numb shoulder, which is really good because that's the worst. That's when it's mostly painful. After that, they get pain medications to stem that little bit of pain where it's really acute. And then we wean the medications down over several weeks. For the first part of surgery, for approximately 4 to 6 weeks, and sometimes longer and sometimes shorter, depending on the amount of pathology, they're going to be in a sling. And they're not really allowed to move their arm. I get them out there to do gentle range of motion exercises called pendulum exercises, where there's not a lot of active motion. I do that really almost immediately. And I have them coming out to stretch their elbow because I don't want a stiff elbow created while we're trying to go ahead and get their shoulder better. After that 4 to 6 week period, then they start to go into a passive range of motion therapy program. And I try to get all of their motion restored, or the vast majority of it, in the first 4 to 6 weeks of therapy. After that, I really begin to shift the passive range of motion to more an active range of motion in a strengthening program. So by 3 to 4 months after surgery, you're really well along. I oftentimes, however, see that there's a few degrees of range of motion that the patient lacks, and over the next year, it slowly gets back as long as they keep working at it. Some patients need more time to get their strength. For instance, when you have a person who's doing a heavy construction-like job where they're lifting heavy amounts, those particular patients need a little bit more time in therapy to really build their strength before they're back in there working that hard job and possibly affecting the repair.
How long would you say most people would be out of work before? That's a big concern that I hear.
It's a very, very good question. So I always tell people, look, how long you're out of work depends on what you do. So I talk to people and I explain it like this. If you have a desk job I tell people, look, take a week or so off because
Sure.
it's quite painful, and likely you're going to take some pain medications in there.
Sure.
You can't drive your car, and you really don't want to go to work when your mind is affected a little bit because it makes you a little
Sure.
affected from the pain medications. And so I say take a week or two off.
Okay.
For those people that are standing on their feet all day, where they're in a sling and they have to, I tell them to take 3 weeks,
Okay.
4 weeks, and if they want to do 2 to 3, I completely understand.
Sure.
As long as they're not taking the pain medications, I'm fine with that. For the heavy construction worker,
Yeah.
I really don't let them go back and do their normal thing until in therapy they've met their strength requirements.
Gotcha.
Those are the guys that I really have to protect because they're the ones they're going to go out there, focus on their job, and then they may injure and say, oh, it's just a little bit of pain, I'll let it go. But not
sure.
really realizing that you need to allow the tendon to heal down to the bone
Sure.
that we prepare. Otherwise, we're going to go back to surgery, and we certainly don't want to do that.
Absolutely. A lot of great information. So what would be your take-home message for everybody, as you look from a shoulder perspective?
So my take-home message from a shoulder perspective is if you have pain in your shoulder that doesn't get better with simple things, a little rest, a little anti-inflammatory over the counter, some gentle range of motion, coming to visit with you, getting that gentle rehab, then go to the orthopedist, say, hey, my shoulder hurts, and let them evaluate you. Because if you have a tear that is progressing, and they can progress if you don't take care of them, you want to identify it because long term you will lose function if it gets to be a large tear.
Sure. Excellent. So I just wanted to say thank you, Dr. Lipton, for being
Thank
on
you.
our show today. Good day and good health.